Please, Dr. Vision.
Thank you, sir, and good evening, everybody. Today we have 10th lecture of the series, and today's speaker is Dr. Habibullah. Habib is already being introduced by sir also in the earlier talk, so I am not going to introduce him again. Just before he starts, let me say a few lines on ventilation and disease-specific settings. As this is a workshop from basic to advanced ventilation, and all of us are very much confident that most of the infants with respiratory distress or morbidity can be managed with non-invasive respiratory support. Having said this, some babies, even 10 to 20% of the infants, may require an endotracheal tube for invasive mechanical ventilation. Over the years, mechanical ventilation has progressed, and over the years in India, clinicians are used more and more invasive mechanical ventilator for some patients. Before we go to invasive mechanical ventilation, let me tell you there are certain factors which are responsible for these specific settings with a mechanical ventilator. First is the which ventilator or what modalities of ventilation you are using. The device itself is very, very important because a clinician should be aware of the device who is what he or she is actually handling. Second important thing, what mode of ventilation we are actually using or we are applying for ventilation. And in our earlier lecture, we have already learned modes of ventilation, different modes of ventilation, basically conventional ventilations, and how we will speak on conventional ventilation only. After few days, we will have another ventilation is a high frequency oscillation ventilation. I think I will restrict his talk to conventional ventilation because by this time we are acquainted with conventional ventilation only. The third important thing is that it is the device. It is not the device which is important. It is the operator who is actually handling the device. Last not the least, the device itself, operator who is handling the device, disease pathology, and also continuous monitoring of the baby on mechanical ventilation are some core issues when you are ventilating a baby. I will not speak much on mechanical ventilation and its disease specific settings. Habib is an excellent speaker. I think Habib will tell us the various aspects and insights of disease specific settings in newborn mechanical ventilation. Habib, please start your lecture.
Thank you, sir. So good evening. Today, I think we are going to discuss about the disease specific ventilation setting. So I will just give some overview of this given different disease condition. We'll cover both the non-invasive and invasive ventilation. So before we should go for ventilation, I think we should have an idea of this core physiology that's related to neonatal lungs, that is particularly lung development, the compliance resistance, what is time constant, the oxygenation versus or ventilation, and the lung protective strategy. I think most of this topic has been discussed in the previous session, so I will touch upon few things in the next few slides. So these are the 5 knobs we usually operated, be it invasive or non-invasive. The first is PIP. How we can adjust the PIP? Just grossly by seeing the chest rise. At the same time, we have to monitor the SpO2 by targeting around 90 to 95%. And also, you can monitor the PCO2 level from the ABG or VBG. And PWP, we can monitor by seeing the chest retraction, and the X-ray, you have to see the lung expansion. And the FiO2 button, you have to usually regulate it, restricted the FiO2 button by targeting the SpO2, again, between 90 to 95%, and the ABG, you have to see the PO2. And the respiratory rate depend on the disease condition and the respiratory drive of the baby. And the flow, I think most of the neonatal ventilator nowadays is flow is automatically regulated, and some ventilator you may control the flow. So what is oxygenation? So oxygenation is basically is equivalent to FRC. That is the functional residual capacity of the lung. That means how much of alveoli is participating in the ventilation. So oxygenation basically depend on two factors. There is the mean airway pressure, there is the descending pressure, and the FiO2. And you all know that MAP equal to Ti into PIP plus T into PWP plus Ti plus T. So how can we increase the MAP so that we increase the oxygen? For increasing the MAP, we let's see this graphics. There is a pressure time graphics. We can increase this rise time by reducing the rise time. We can increase the area under cup. Second, we can increase this PIP. Third, you can increase the TI. Fourth, you can increase the PWP also. And the fifth one, you can increase the rate. So by doing this five, you can increase the mean airway pressure, thereby increase the oxygenation. Then coming to ventilation. So ventilation is basically the removal of carbon dioxide. So it's depend on minute ventilation. That is the tidal volume into respiratory rate. So how we can control the tidal volume? Tidal volume basically depend on delta P. That is the difference between PIP and PWP. So by increasing the PIP, we can increase the difference, thereby increase the tidal volume. Second, you can increase the rate to increase this minute ventilation. But one important thing that whenever we increase the rate to increase the minute ventilation at the same time, we are basically cut down the expiratory time also. So whenever you increase this respiratory rate for increasing minute ventilation, you have to carefully see the expiratory time also, so that each alveoli get adequate time for expiration. Otherwise, there will be carbon dioxide retention. And the third parameter we should consider is the ET2 parameter. That is, if there is a blockage in the ET tube by secretion, if the kinking of the ET tube, that may also decrease the carbon dioxide removal process. If we use a narrower tube, that also decrease the carbon dioxide removal process. If you not cut the ET tube length from the proximal end of the ventilator, that also increase the dead space volume. That may also reduce this carbon dioxide removal process. So whenever a baby admitted to our unit, whatever may be the pathology, with the fake exception, our aim is always to manage the baby non-invasive ventilation. So, but it's not like that we always successful by using this non-invasive ventilation. In certain situation, we are failed. So in that scenario, we have to intubate the baby. So these are the some broad guideline when should intubate the baby. First, if the baby have inadequate or absent respiratory effort, like there is weak or intermittent effort, or there is a frequent apnea, that is more than 6 event per hour, or severe apnea that require positive pressure ventilation. In that scenario, you may intubate the baby. If the work of breathing is very high, like marked retraction or severe tachypnea, that is the rate is more than 90, you can also intubate the baby. If the oxygen requirement is very high, around more than 40 to 60%, or if the baby having the labile SpO2, if you suspect the PPH in that scenario, you also intubate the baby. The blood in the ABG, if you see the pH is less than 7.2 and it's not improving, and the first 3 days, if the PCOT is over 65 and the beyond 72 hours, so after 3 days, if the PCOT more than 70, in that scenario also you have to intubate the baby. And in certain disease condition, baby having respiratory distress, but there is
आज भर की
there is a
पार्ट है ना,
contraindication.
क्योंकि बहुत सारा जो लोडिंग गया है ना, तो सारा
There is some
सब
contraindication for non-invasive support, like if the
50
baby have intestinal obstruction.
इसलिए 8 है मैं कल
Just a minute.
फ्लूड रेट 8 है
Okay.
मेरा
Please mute.
हाँ,
Anshu, please
डिक्रीज
mute.
किया। फिर कल से पूरा मेंटेनेंस
Anshu, please mute. What is this?
Okay. The last point is that the baby having the respiratory distress, like mild to moderate, but there is contraindication for NIV, like if the baby have intestinal obstruction or perforation, or if there is recent GI surgery of baby having CDH, in that scenario, even the baby has mild to moderate respiratory distress, you can't manage the baby non-invasive ventilation. So in that scenario, you have to intubate the baby. So after deciding this baby require mechanical ventilation, then you have to, there are 3 factors you have to consider, whether you have to use the conventional mode of ventilation or high frequency. I think sir already told. Still now we have not discussed the high frequency modality of ventilation that will deal with later on this series. So today I will confine myself on the conventional mode of ventilation also. So after deciding that you have to suppose I am using this conventional mode of ventilation, then the second factor you have to consider, you have to use the patient trigger mode of ventilation. That is either use the SIMB or SIPP mode of ventilation. At the same time, we should combine this modality with volume guarantee so that there will be less volume trauma. Another important thing, whenever we put a baby on mechanical ventilation, that always should be based on suspected lung pathophysiology. And what are the temporal change of the lung pathophysiology will happen with time. And another thing should be considered, what will be the how the lung will respond to this intervention, that is mechanical ventilation. These three factors you have to should consider. And ventilation setting should be always individualized. Each baby, I think each baby will behave differently. Each baby have different pathophysiology. And even in the same baby, the pathophysiology change over time. So you can't put a same setting for all baby. Like if an baby an RDS, you can't set the one setting for all RDS baby because all RDS baby behave differently. Like one size will not fit to all. We have to tailor it accordingly based on disease pathophysiology. The most important thing is that from the time I also agree that intubation, sometimes emergency you have to put a tube, but putting out from the tube on glottis is it's not so easy. So from the time you intubate the baby, you have to actively plan for weaning. Otherwise, you will end up in a situation from here where the escape will be very difficult. Our goal for mechanical ventilation always for adequate gas exchange, but at the same time, you have to correct the lung function for which you have to ventilate, also reduce the work of breathing. At the same time, you have to minimize the ventilation-induced lung injury. So how can we reduce the ventilation-induced lung injury? We have to usually use the lung protective strategy. This have to avoid the atelectative trauma. I think this PBLO is known to all. We have to prevent this atelectative trauma. We have to open the alveoli and also keep it open. At the same time, we should not go for this beaking part of this PBLO so that volume trauma can be avoided. Now coming to disease-specific setting. First is RDS, that is respiratory distress syndrome. I think this developmental stage of lung, you all know that is starting from embryonic stage, then pseudoglandular, canalicular, saccular, and the alveolar. It is a canalicular stage from where the acinus or ventilatory unit is to form, that is from 17 to 26 weeks of gestation. But postnatal viability is possible only in late canalicular stage. That is from 20 to 28 weeks, from which the rudimentary air sac still form and the capillary organization also begin, and the type 1, type 2 pneumocele also differentiated produces surfactant. So if a baby born on RDS, what biochemical abnormality you will expect? That is surfactant deficiency. So there will be increased surface tension. I think we all know Laplace law, that is the pressure according to distance to open this alveoli is equal to 2T by R. That is the alveoli is collapsed, that is radius is low. So to open these alveoli, the pressure will be high. These are the functional abnormality we will expect in the RDS baby. Like there will be fewer number of functional alveoli. So the surface area for gas exchange also reduce. If the baby gestation is decreased, there is a diffusion barrier. That's mean from the functional capillary to functional alveoli to nearest capillary distance also high. So there will be reduced diffusion of the gas. And the septal wall thickness also inversely proportional to gestational age. There is main airway also is not cartilage is not cool to form. There is the chance for airway collapse, and the chest wall is also compliant. There's also increase the work of breathing. So you will get a RDS baby with the lung mechanics, like you have to reduce compliance. In the mild to moderate RDS, the resistance will be normal, but in severe RDS, resistance may be increased. So time constant will be short and FRC is reduced. So you are basically dealing an alveoli that is very easy to inflate, at the same time very easy to deflate also. So RDS is basically an uniform lung disease. That is the all over the lung, the dynamics is same. So it is basically an one compartment model. So our strategy, always lung protective. As there is diffuse alveolar microatelectasis, we have to first open this alveoli. There is a recruitment maneuver by providing adequate pressure. Then we have to maintain adequate pressure after opening this alveoli so that can avoid the atelector trauma. At the same time, you should avoid excessive tissue stretch. Our strategy will be aggressive NIV with the lowest level of support. At the same time, we also avoid the oxytrauma by reducing the FIR also. So mild to moderate, the first approach will be non-invasive, be it CPAP or NIVB. If you start the CPAP, start the CPAP pressure of 5 to 6 centimeter water. But if the BFI require FI to more than 30%, and there is also retraction, respiratory distress, you can increase this CPAP pressure to 7 centimeter order. If the FI to decrease, you can decrease this pressure also. But at the same time, if the baby required FI to more than 30% with the CPAP pressure of 5 or 6, you have to give the surfactant, that is, should be early rescue surfactant. If you use NIPPV as a primary mode, you should start the PWP around 5 to 6 centimeter water. Again, if the FI to requirement increase, then you have to increase the PWP also, can go up to maximum 7. Then you have to decrease this PEEP level if the FI to requirement come down. The PIP usually start with 14 to 18 centimeter water. As the PIP may control this ventilation part, that is, if the PCO2 is suppose more than 55, then you have to increase the PIP so that there increase the minute ventilation. If the PCO2 is less than 45 in the blood gas, that means there is hypocapnia, then you have to reduce the PIP to minimum of 12 centimeter. Rate usually start with 40, but if the PCO2 is 55, you can increase the rate. But the first parameter, if the baby having hypercapnia, that is inadequate minute ventilation, the first parameter you have to chase is the PIP, then you can put the knobs of the rate. If the PCO2 is less than 45, you can reduce the rate, but again, you have to adjust the PIP first. Then only you can put the rate down. And FI2 usually start from 21% to target pre-ductal SpO2 of less than 85%. If the pre-ductal SpO2 less than 85%, you can temporarily increase up to 60%. Then you have to reduce up to 21%. So if you maybe RDS, severe RDS require mechanical ventilation, this will be our setting. So preferred mode is either you have to use SIMV with pressure support mode of ventilation or SIPPV, and that should be always volume targeted. That we have to use always use hybrid mode. Start with tidal volume of 4 to 6 ml per kg. And if the baby weight is low, you have to keep this tidal volume on the higher side. Why so? I will explain in the next slide. Then you have to start the PIP around 14 to 16 centimeter water and PW 5 to 7. The important thing is that this is the initial setting. So after putting a baby on the tube, you have to give surfactant. So after giving the surfactant, the lung mechanics is completely changed. So then you have to adjust this PIP and PWV also. The starting rate are usually 50 to 60, and TI at the time constant is low. We keep this TI is 0.3 to 0.35. And if we use this SIMV with pressure support, the support should be pressure support part should be so that you can achieve 2/3 to 3/4 of the safe tidal volume, or you may use 30% of the PIP of SIMV breath. Now, why we use the higher tidal volume in case of baby having the lower the weight? Suppose in this example, two baby having RDS, one is 1 kg, another is 2 kg. I set the tidal volume in ventilator 5 ml per kg, but putting a flow sensor at the proximal end, it will create a dead space. It's created around 0.6 to 1.2 ml, suppose. For simplification, I put in 1 ml for this dead space volume for this flow sensor. So the alveolar tidal volume, basically, whatever tidal volume set minus instrumental dead space. Suppose in the table you say for 1 kg baby, you say the tidal volume 5. So the alveolar tidal volume is 4 ml per kg and dead space fraction around 20%. And the same 2 kg baby, the alveolar to achieve the alveolar ventilation tidal volume of 4.5 ml per kg, the dead space fraction is 10%. So lower the weight, there is a higher dead space fraction for this tidal volume. So we have to keep the tidal volume on the higher side. Now coming to ventilator setting, how we can adjust this PWP, PIP rate, T I time and the FiO2. As I already told, we start this PWP around 5 to 6 centimeter water, but the baby required more than 30% of the FiO2, we can go to PWP up to 7. Again, same thing also in PIP, start with 14 to 16, but if the baby is hypercapnic, then you can go to maximum of 25, 26. If baby hypocapnic, you can reduce this PIP up to 10 to 12. And the respiratory rate also, you can start with 40, 45, and the PCO, if there is PCO more than 55, these values basically from the ABG, not the BBG. In the BBG, this parameter around 60, 65. If you can go up to 50 if there is hypercapnia, and if the baby hypocapnic, you can reduce this PIP of 10. And the I time, we start with 0.3 to 0.35. Then you can reduce this I time later on. And if I do starting from 20%, gradually titrate according to speed to target. So now coming to the meconium aspiration syndrome. I think you all know this pathophysiology, mass pathophysiology is a bit complex, it's multifactorial. This basically, there is surfactant dysfunction, there is also airway obstruction, and there are also vascular involvement. If the meconium completely obstruct the airway, there will be atelectasis. If there's a partial obstruction, that may lead to air trapping. That's meconium also directly cause surfactant dysfunction. And also there is pulmonary vascular response, there will be vascular remodeling, the abnormal response to NO, later development of PPH also. So we make a three phenotype in case of mass, that is surfactant dysfunction, increased airway resistance, and pulmonary hypertension. But problem is that mass is basically an heterogeneous disease. It's variable from one infant to next. It can, even in the same baby, the same pathophysiology change, rapidly change during the course of their NICU history. So we have to individualize this ventilatory setting for each baby, and you have to frequently assess the suspected pathophysiology at the same time. So what happens if there is surfactant dysfunction? There will be atelectasis. So whatever blood come from the right ventricle, that will not be oxygenated. That's mean there will be right to left intrapulmonary shunting. So you have to provide adequate PEEP and the MAP so that you can open this alveoli. So at the same time, you should minimize this over expansion. That is the distension of this normal alveoli also. If this pressure, excess pressure over distended this normal alveoli, it will compress this capillary. So there will be VQ mismatch. Airway resistance, I already explained. That's either the complete obstruction that may lead to atelectasis, or if it's partial obstruction that may cause air trapping. How it's caused air trapping? Let's see this graphic, this diagram. During inspiration, we all know there is a negative pressure, interthoracic pressure. So there will be opening of this major airway. So air can pass from the side of the meconium into the distal alveolar unit. But during expiration, what happened? It is positive interthoracic pressure compress this airway so that this air will not escape from the side of the meconium. So there will be air trapping. Now, in mass, you will get pulmonary hypertension. The main pathophysiology for pulmonary hypertension, basically, and hypoxemia and the inflammation. In addition, there is abnormal NO metabolism. We all know the nitric oxide is the main pulmonary vasodilator. If In a metabolism is abnormal, there will be abnormal tone of the pulmonary vasculature, there will be PHN. In addition, there is air trapping may cause over distension also that can compress the pulmonary capillary, causing the pulmonary hypertension. So management goal in case of MAS is you have to identify the predominant pathology. Is it surfactant dysfunction, or is there is a atelectasis or airway obstruction pattern, or there is a PPGN component is most. So you have to assess the underlying pathophysiology. Accordingly, you have to manage. So if you see the respiratory dynamics in case of MAS, there is atelectasis with hyperinflation, there is intrapulmonary shunting with inflammation, PPHN. So you will get there is increased resistance with decreased compliance. So time constant will be high in case of MAS baby. Important thing is that whenever you ventilate baby, the two things, one thing you should keep in mind, the early phase of MAS, the pathology will expect there is surfactant dysfunction and the airway obstruction. But the later on, after 24 to 48 hours, the pattern will be changed. That is, inflammatory pattern will be predominant. That is just like RDS, ERDS like pattern. And two principle we always to be kept in mind whenever we are managing a baby with MAS. The first principle is oxygen. We have to be generous with oxygen. In NICU, we usually restrict oxygen very cautiously. But in this scenario, you have to be generous. But generous does not mean you have to provide oxygen unregulated. Suppose baby requires FID around 60%. You can give the FID of 100%. So why we have to be so generous with oxygen in this case MAS? Because if we not provide oxygen adequately, there will be intermittent hypoxemia that may cause development of the PPHN, or if already PPHN is developed, there will be worsening of the PPHN. By increasing FIA to as a MAS is a phenomenon of the term baby, the toxicity for will be less, like hot toxicity we usually consider in the preterm baby, like eye toxicity, this is for ROP or lung toxicity. So we always target the SPOT is 90 to 95%. Second principle you have to keep in mind, that is, do not delay the intubation, because in some MAS you may able to manage by non-invasive method of ventilation by CPAP or NIV. But if we delay the intubation, you will end up in a situation from which the escape will not be so easy. So you will be trapped. So if the baby required intubation, need intubation, you do not delay the intubation process in case of MAS baby. One common belief we have is we can't give CPAP in case of meconium aspiration syndrome, but this is not true. As I already discussed the pathophysiology, there is surfactant dysfunction that may cause atelectasis. If the chest X-ray showing the predominant alveolar dysfunction, we can give CPAP in MAS also. Another way, CPAP also improve this gas exchange. How it's improved gas exchange? Let's see. I already explained this figure, that is what happened without CPAP. Now, if we give the CPAP, if we provide the CPAP, it is a figure T. That is basically you are providing the positive pressure so that during expiration, this airway will not collapse, so that trapped air can come out from the side of the alveoli. So by providing the CPAP, you are basically avoiding this air trapping phenomena in meconium aspiration syndrome. So you can use CPAP in MAS also. So initial start with CPAP pressure of 5, but if the baby required oxygen more than 40%, or if there is distress, you can go to up to 7. But at the same time, you have to see the chest X-ray. Also, you have to monitor clinically. You can also decrease the pressure up to 4 if the FID requirement come down. Can you use NIPPV in CPAP? Yeah, NIPPV in MAS. I think whenever you are using the NIPPV in MAS, you have to be very cautious. Why? Because as you already discussed, compliance in case of MAS is very variable. because some alveolar collapse, some are overinflated, but the resistance is always high. So you have to give long E time for empty of the lung, empty of the particular alveoli. If the expiratory time is short, then this particular alveoli will not be exhaled before the next breath arrives. So there is this create an air trapping autopic phenomena. But most of the NIPVV we are used basically non-synchronized. Only around 10 to 15% breath are synchronized to the baby breath. So most of the breath, when the suppose baby is expiring, at the same time ventilation is give positive pressure. That's means it affect this exhalation process in the baby. So it will further worsen this phenomena. There will be more air trapping autopip. Well, this I think this is a physiological explanation, but we are using NIPVV in the mild or moderate case of mass. That's not lead to air leak or autopip phenomena. If we using the NIPVV in mass, you can start with CPAP peak pressure of 5, then can increase up to 7 depending on the FiO2. And the PIP we start with it's Stam baby. We start with the PIP around 18 to 20. You can go up to 25 centimeter water. Now, if your baby with the mass intubated, then you have to identify the disease pathophysiology. If it's predominant area obstruction pattern, there will be more increase in resistance. There will be increased time constant. So you have to keep the PWP always less than 6 centimeter water. And the rate should be kept lower side around 20 to 30 so that there will be short eye time and adequate expiratory time that can avoid this gas trapping phenomena. The predominant alveolar disease pattern that is just behave like an RDS. So you can give the PEEP up to 8 centimeter water. And the tidal volume required for both cases is usually higher side because there is increase in alveolar dead space. That is, particular alveolar is not participating as exchange. Then you have to keep this tidal volume on the higher side. And two important pillar whenever we managing this mass, that is INO administration for the PPH, and you should treat the PPH aggressively. And if the baby is intubated and oxygenation index more than 5 to 7, FiO2 is more than 40 to 60%, you give surfactant an early phase of this management. Otherwise, you will be trapped. So INO administration or any pulmonary vasodilator and surfactant administration very cornerstone for minor mass. Our strategy always should be gentle. You can go PIP up to 25. You can accept this permissive hypoxemia, that is, you can PO2, you can tolerate PO2 up to 50 and permissive hypercapnia up to 55, or in venous blood gas, you go up to 65, unless and until pH is above 7.25. But if this ventilation strategy, this conventional mode of ventilation fail, you have to go for high frequency mode of ventilation. Now coming to third disease pattern we all usually encounter in ICU, that is a lung hypoplasia disorder. Why is lung hypoplastic? Because of this decreased lung fluid. The lung fluid decreased because of an oligohydramnios, that may be because of PROM or severe renal dysfunction, or there may be genetic obstruction. There will be external competition in the form of like thoracic wall abnormality, or there may be compression from the thorax itself like CDH, or from intra-abdominal pathology like ascites, and some neuromuscular disorder like myopathy, akinesia also cause this lung hypoplasia, and if there is omphalocele, that also may cause lung hypoplasia. So lung hypoplasia management is very difficult. It's also very frustrating. So basically there is two events occur in the hypoplastic lung. One is the lung hypoplasia, another is pulmonary vessel development abnormality. The lung hypoplasia, a degree of lung hypoplasia depend on the pathology. Pathology hit which trimester. If it affect the early trimester, early part of gestation, that lung will be severely hypoplastic. If it's affecting the late part of gestation, it does not affect so much. The second is pulmonary vessel abnormality. Second is pulmonary vascular abnormality. We all know this vessel growth is interlinked always the lung growth. If the lung growth is impaired, there will be impaired vasculogenesis. So there will be underdevelopment of the pulmonary artery and the arteriole, decreased NO synthesis. That is, NO is the main pulmonary vasodilator. Not only that, there is also increased phosphodiesterase. So they break down this NO. And there is alter angiogenic factor like the VEGF, and the impaired to NO response is also reduced. And there is also increased endothelin 1, that is the pulmonary vasoconstrictor. So ultimate effect is that if a baby born is pulmonary lung hypoplasia, there's a pulmonary vascular response at birth to inflation or oxygen is impaired. What is the response to oxygen in the pulmonary vessel? Oxygen basically act as a pulmonary vasodilator. But if the vessel is hyperplastic, this response will be blunted. So afterward, this oxygen will not act as a pulmonary vasodilator. So three main pillars to manage this baby, that is, you have to put gentle ventilation because there's always high chance for air leak. At the same time, you have to ensure adequate gas exchange and should avoid this portioning of PPH also. So it's better to start with high frequency mode of ventilation. If you suspect the disease pathology, suspected pathologies, hypoplastic lung, I think this part will be deal in the later part of the session. So I will confine myself with the conventional mode of ventilation, that is the SIMV. We should start with tidal volume around 4 to 5 ml per kg. Why that low tidal volume? Because the lung is hypoplastic. That means the FRC are usually low. So tidal volume require also be low. So tidal volume we start is lower side around 4 to 5 ml per kg. In the pressure, there is a PIP and the PWP. So if the FRC is low, I think the mean airway pressure to inflate this alveoli also be low. So we have to start this pressure also on the lower side. The important difference from the management of RDS baby is that in RDS we usually start the pressure from the higher side, then it gradually titrate. But in hypoplastic lung, it always better to upward. It always better to titrate this pressure from lower to higher side so that you can avoid this ear leak phenomenon. Then as the tidal volume, we keep the lower side. That's mean to ensure adequate minute ventilation, you have to keep this respiratory rate on the higher side. And the I time usually kept on 0.3. And the initial FI2 you start with 40%. And the target SpO2, in the first hour, you target around SpO2 more than 80%. But it's always target between 90 to 98% later on. And the PCO2 target, you can tolerate up to 55. And if it's venous blood gas, that can tolerate up to 65. And chest X-ray, have to see lung expansion up to 8 to 9 rib. And this is then contralateral lung, not the ipsilateral, that is hypoplastic lung. Now coming to the BPD. So bronchopulmonary dysplasia. What is bronchopulmonary dysplasia? Bronchopulmonary dysplasia is basically the baby born in RDS, that is premature lung. You ventilate, be it invasive or non-invasive, weeks to month, they will land up in a BPD. So RDS is basically deficient of surfactant, and the BPD basically have different pathophysiology. There is lung injury and also there is delayed alveolarization. So BPD basically phenomenon of the preterm. More specifically, it is a phenomenon of extreme preterm. If a baby born with extreme preterm, to intubate such baby, that's caused volve trauma, that's concurrent infection or oxygen-induced trauma may lead to inflammation. So if the body responds, this inflammatory response is good, they can repair this process. So that will be normal phenotype. But most of the cases, this reparative process is abnormal. So there is impaired alveolarization and dysregulated vascularization. The baby land up in BPD. So if a preterm baby, this is a pathophysiology of BPD. There's a preterm baby. If you ventilate and provide excess volume, that may cause volve trauma. Excess oxygen may cause oxytrauma. And internal, the postnatal infection may also increase this inflammatory mediator, and the preterm infant also have higher incidence of PDA. That may also increase the pulmonary edema. So all these phenomena ultimately lead to inflammatory response that affect all the three components of the pulmonary system. That is the airway, vessel, and the interstitial system also. So you will basically get these three phenotypical presentation. That is the involvement of the lung parenchyma, that's maybe homogeneous, that's this, alveolar arrest, and heterogeneous, that is formation of microcyst, macrocyst, fibrosis, atelectasis, and pulmonary vessel usually underdeveloped, and there is hyperreactive also. There will be pruning, there is remodeling. The airway, that's main about the central airway, there will be tracheobronchomalacia, that also is small airway, that's also be like an reactive airway disease like. I think all of you know this definition of BPD, that is starting from the Northway, that's 1967, who first coined this BPD. From this recent one is 2001 by NIHA, and the latest is 2018 by NICIST, and latest is Jensen. But I am not interested this definition. From management point of view, you have to see what is the pathological classification of BPD. That is the old BPD and the new BPD. What is old BPD? This BPD basically described by Northway. So in that time, this late preterm infant, they ventilated for prolonged period, and this pressure also unregulated, that caused this alveolar injury. There is atelectasis, inflammation, there is diffuse fibroproliferation, that also cause epithelial airway injury, that also large airway abnormality. Then there will be pulmonary vascular remodeling. So old BPD basically give this either severe or chronic severe form of BPD. But new BPD, it's not like that. We are not getting the old BPD nowadays, as more and more extreme preterm also surviving today's, and we are providing different modality of ventilation. So as this survival rate of the extreme preterm increase, we also get the old BPD nowadays also. And the new BPD is basically the phenomenon of arrest in alveolarization. As I already show you, that is, if the baby born late canalicular stage or the early saccular stage, that means that alveolar sac is not fully formed. The baby born in this stage, their alveolar development will be arrested. So you will get basically a large simplified alveoli. So that decrease this surface area. You will rarely get this fibroproliferative changes or epithelial injury, and you may get some smooth muscle thickening in case of new BPD. So new BPD ultimately gives us the mild to moderate category of BPD. We all know this stage of BPD or X-ray classification. Stage 1 BPD is basically, if you see the X-ray, there will be reticulogranular-like appearance, just like RDS. If you see the stage 2, there will be some confluent density on the background of homogeneous opacity. And stage 3, you will get this microcyst. And stage 4, basically bubbly appearance, and there will be generalized macrocystic area. Chest X-ray usually use a hyperinfantile. It's a stage 4 BPD. Stage 4 BPD is basically severe form of BPD. So if a baby born with RDS, now after 1 to 2 months, they change to BPD, the lung mechanism, what will be the lung mechanics? There will be alveolar simplification. That's mean basically there is increase in dead space volume. There will be atelectasis, and the loss of elastic recoil may cause compliance to increase or decrease. And the airway malacia or epithelial injury increase the resistance. If you see the phase of BPD, that is early, evolving, and established BPD. This phase of BPD is very important, because whenever we are ventilating baby in the early and the evolving phase of BPD, there is the first 1 week is the early phase, the 1 week to 36 weeks is the evolving phase. We can diagnose the BPD by 36 weeks. Before that, we can't diagnose it. We can coin the term either early or evolving phase of BPD. But our aim, ventilation aim strategy is different. Whether it is early or evolving, whether it is established. Early and evolving phase, our aim is always prevention of BPD. But if the BPD is established by 36 weeks, our aim will be shift. That is, you have to give treatment for the BPD. That is completely different from the early or evolving phase. So after the baby, what is the prevention aspect we can think? That is, if we prevent this prematurity, or if we give the anti-steroid, or if we treat the chorioapneitis and proper IUGR management, we can reduce the BPD. But after birth, what can we do? That is by providing the early CPAP at the delivery point. By providing the early CPAP, you can reduce the BPDs almost 11%. And by giving the early rescue surfactant, that is surfactant within first 2 hours of life, you can reduce this BPD 30%. Another important intervention is a laser technique. Surface intervention should be a laser technique that can reduce death or BPD around 43%. And the gentle ventilation, that is a volume grounded ventilation, can reduce the death or BPD almost 27%. So these are the 4 intervention we can do after preterm baby born. That is, we have to provide delivery room CPAP, early rescue surfactant by the laser technique, and the volume granted ventilation. The other intervention is not part of discussion for today's session. That is like vitamin A, caffeine, steroid. Then at 36 weeks, after the baby diagnosed the BPD, there are a lot of intervention, but I will confine myself with the ventilation strategies only. So in new BPD, what is a new BPD? New BPD, that is basically an arrest in alveolarization. So you will see almost RDS-like lung. That is, all the lung parenchyma behave similarly. There is a one compartment model. So it's very easy to ventilate such baby. If you see the respiratory lung mechanics, there will be high dead space volume, resistance will be high, compliance may be normal or decrease. So it's a new BPD. If we provide adequate non-invasive respiratory support, either from NIPVV or CPAP with good nutrition, and if we also treat this associated problem like infection or management of PDA, baby will outgrow by time. There will be lung maturation. You can gradually discontinue the support. But management of new BPD is very simple. But the problem is that if we provide inadequate support to baby with BPD, even in the evolving or early phase of BPD, that may lead to impaired growth, that in the somatic, alveolar, as well as pulmonary vascular. So there will be VQ mismatch that's made it to contribution of pulmonary hypertension. So providing adequate support to the baby of BPD is very important. So if the baby either are evolving or established PPT, you are managing the baby on non-invasive ventilation, but the baby having the severe outcome breathing, if there is a growth parameter is impaired, the baby is not tolerate the age-appropriate activity, there is excessive sleeping, or always agitated when awake, or there is developing a progressing pulmonary hypertension, better to intubate such baby. So practice of avoiding intubation at all cost is basically cause more harm than the benefit in some infant with BPD. So you have to timely intubate such baby. So if we intubate such baby new BPD, the ventilation strategy at this dead space volume is higher. So you have to keep the tidal volume on the higher side, that is around 5 to 8 ml per kg. To keep the rate on lower side, and inspiratory time keep 0.4 to 0.5 centimeter, keep slightly higher side, and you have to provide adequate PEEP to open this alveoli. Also adequate pressure support if you using this SI with PSP mode. Now coming to severe BPD. I think management of severe BPD is extremely difficult. It's not like the all preterm baby after birth will be develop new BPD. If the baby having severe RDS, if there is higher oxygen needed at the birth, baby having complication like PIE or pneumothorax, there may be pulmonary hemorrhage. Some baby initial course is smooth, but after 7 to 10 days, there is concurrent infection or PDA. There will be deterioration of the lung condition. So ultimately, this kind of baby, this kind of preterm infant will land up in severe BPD. So in severe BPD, you will basically get all 3 phenotypical involvement in varying proportion. There is involvement of the lung parenchyma, involvement of the pulmonary vascular and airway. So severe BPD is basically a 2-compartment model. What is 2-compartment model? You will get, there is some atelectatic unit, there will be some hyperinflated unit. So in atelectatic unit, that is the first unit. So there will be relatively normal compliance in the resistance. So time constant will be short. But those alveoli, that is over distended, there is a loss of elasticity. That's mean the resistance will be high. So you have to provide, there is a time constant also high. So it's very difficult to ventilate such a baby having different lung pathophysiology, the different part of the lung. I think all of you have seen this type of X-ray in NICU. That's if you see this X-ray, there is basically stage 4 BPD. If we see the right lower portion of the lung, there is some haziness. That means there is alveoli is collapse. So alveoli is collapse. That means there is no ventilation. So blood coming from the right ventricle go to the left atrium, and there is no oxygenation. So there is intrapulmonary shunting, right to left shunting. If it's the right upper part, the alveoli is open, but it's not adequately open. There will be ventilation perfusion, but that is not good. There is also mismatch. If we see the left lower part, the blacky appearance, that means the the alveoli is overinflated, there is hyperinflated. These hyperinflated alveoli compress this capillary, so there will be no ventilation, there will no perfusion. So this basically increase the dead stress volume. And the left upper part, I think this part is something good. That is alveoli is optimally distented, and there is also perfusion is going on. So in severe BPT, basically there will be air trapping along with major airway problem, that is the airway malacia, along with segmental atelectasis. So ultimately, you are having the higher dead space volume along with higher airway resistance, and compliance will vary. There's maybe normal, decrease, or increase. So management goal of a severe BPD is something it's not like acute care model. You have to the model is chronic care. So here you have to provide adequate support. It's not like that you have to remove the support suddenly. What we usually do in RDS or in acute management of any baby. But in baby on severe BPD, the management is always chronic. You have to provide support for a long period so that there is adequate lung growth. And at the same time, you have to provide the optimal nutrition. This will facilitate this growth process. So management of severe BPD model is chronic care model. You have to providing the support to a prolonged period of time so the baby can outgrow from this process. So ventilation strategy here is have to providing the support. In the early and the evolving stage, our aim is always reducing the lung injury. But when the babies develop severe BPD, that's mean our goal is shifting. So our goal is we have to provide the support, have to recruit the lung. At the same time, have to minimize the air trapping. At the same time, have to also minimizing this ventilation-induced lung injury. So lung injury is not the first phenomenon. Our first aim is always to provide the support. So what will be your ventilation setting? So in the mild to moderate BPD, you can start the tidal volume of 5 to 8 ml per kg. And the PWP around 6 to 8 centimeter water. And I times should be kept around 0.35 to higher side and 0.45. The rate to be around 20 to 40. This is SIMB setting, basically SIMB plus PSG setting, and the SPO2 target will be 90 to 98%. The target PCO2 we can tolerate up to 6 to 65. But in chronic BPD, tidal volume you can go up to 6 to 12 ml per kg because there is more loss of dead space volume. And the peak you can go up to 10 or 12 centimeter water because there is airway malacia. You have to open this airway also. Strain this open airway, you have to keep this PW also higher side. And I time also keep the higher side because resistance is high. So you have to give adequate inspirator time so that this gas will come to the alveoli. At the same time, you have to provide an adequate expirator time also. So by default, you have to keep the rate on the lower side. Let's see why we choose this tidal volume on the higher side. As I already told, there is in BPD patient, the resistance is always high and the compliance is variable. So what will have in the time constant? Time constant is always high. So as the time constant is high, you have to keep this ventilator at the lower side. So if you keep this ventilator at the lower side in the lower tidal volume, the minute ventilation will not be achieved, as minute ventilation equal to respiratory into tidal volume. Suppose, for example, I am keeping a baby of RDS baby, weight is 2 kg, tidal volume is 5, and respiratory is 40. For RDS baby, this setting is good. The BPT baby of 2 kg, if we set the tidal volume 5 and the respiratory rate, you can set 40 because time constant is long. You have to keep this rate lower side. So if we keep this rate lower side, so minute ventilation will be reduced. So to increase this minute ventilation, you have to increase this tidal volume. Otherwise, you can't achieve the adequate minute ventilation. So for this, larger tidal volume required to achieve this adequate minute ventilation. It's the first reason. Why should you use this tidal volume on the higher side? Second issue is there is a leak. Whatever we set the ventilator, that will not ventilate the alveoli because there is increased dead space in the alveolar level also, as there is heterogeneous inflation and the frequent air trapping increase the alveolar dead space. That's lead to wasted ventilation. There is also increased anatomical dead space because there is tracheomegaly, bronchomegaly, there is increased alveolar dead space. And another factor is also peritubal leakage also high. Babies ventilated for a prolonged period, there will be dilatation of the glottis, there will be always peritubal leakage. So these all leakage, for this region, we have to keep this tidal volume on the higher side. Now coming to how we can decide the rate and inspiratory time in case of severe PPT. As I already discussed, this severe PPT is basically in two compartment, but in reality, it's basically a multi-compartment model. There is lots of alveoli that also behave differently. This is to extreme unit, we can use this two compartment model. I think I forget to add one slide here. That is how should we use the SIMB with PS or SIPPV in case of severe PPT? The answer is in severe BPT, the ventilator modality have to choose SIMB with PSP rather than SIPPV. Let's see why. Because if we suppose in a severe BPT having the heterogeneous lung disease, so there are some slow compartment that is having the long time constant, and there are some fast compartment that is a short time constant. So if we choose the ventilator modality of SIMB with pressure support, in SIMB breath will ventilate this slow compartment. So you can control this TI and the TA and keep the rate on lower side. So it will ventilate this slow compartment. And the first compartment will be ventilated by this spontaneous breathing. We all know that spontaneous breathing TI is low. This component and the first component TI is also low. If we provide adequate support, this spontaneous breath with adequate PS with ventilate this first component. So if we choose this SIMB with PS, we can basically ventilate slow compartment and the fast compartment also. So that ultimate minute ventilation will improve. But if we choose the SIPVV in such case, we are basically cut down this expiratory time. Why? Because this all the breath will be supported by the ventilator. So there will be more air trapping if you use the SIPPV in case of severe PPT. Now, how we can choose this PEEP level in case of severe BPT? Severe BPT basically behave like an obstructive lung disease pattern. So you have to choose PEEP at strain this airway so that prevent the collapse, and that will also help to complete exhalation of the tidal volume. How can I achieve? How can we determine this? Whatever PEEP I said is optimal. There are 5 ways you can determine this PEEP level is optimal. First, you can see the chest X-ray. If there is 8 to 9 dB expansion, that is good. Then you have to see the patient ventilator synchrony. That is important. If the patient ventilator synchrony is going on, that means the PEEP level is optimal. How? I will explain the later part of the slide. Then you can see this ventilator graphics also. You can see this if there is auto PEEP or airlick phenomena from this ventilator graphics. And the last way, there is documentation for airway Malaysia and the bedside PEEP titration by using bronchoscopy. I think we don't have this facility most of the center in our country. So by 3 ways, you can determine this optimal PEEP. You have to see the chest X-ray, have to see the ventilator graphics, and you have to see the patient ventilator synchrony. Now coming to the how patient ventilator synchrony, by seeing this, you can confirm this PEEP is optimal. Suppose in a baby, suppose starting from here, baby with severe PPT, that is terribly tracheobronchomalacia. That means there is always chance for auto PEEP, that is inadvertent PEEP. That's the intrinsic PEEP. There is a collapse of the tracheomalacia during expiration that will create an intrinsic PEEP. So if the set PEEP, that's a hot PEEP, I said the ventilator is less than the intrinsic PEEP, baby will have to give more effort to overcome the intrinsic PEEP. Suppose, let's see this diagram. Suppose there is creating of around auto PEEP of +6. So when the baby breathing, we have to overcome this auto PEEP to trigger a breath. That's mean baby have to give more inspiratory effort to initiate the breath. That's ultimately patient. They will struggle to initiate the breath. That's lead to synchrony of the ventilator and ultimately cause air hunger and excessive work. So if there is patient ventilator synchrony loss in patient trigger mode of ventilation, that's mean PEEP is not adequate. Another important thing, another important thing is that if the baby is tachypneic on ventilation, that's mean baby is not getting adequate support or adequate minute ventilation. Then you have to adjust the rate, GI, and the pressure support. Now, one slide about the BPD-SPL. BPD-SPL pathology, we all know that is because of the bronchomalacia, and there is increased secretion and the bronchospasm, the terminal part, that's caused severe hypoxemic spell, that is called BPD-SPL. So for management of the BPD-SPL, you have to target is pathology, that is to reduce for reducing the secretion, you have to sedate the baby. If the baby are non-invasive ventilation, you can use pedicloryl or fentanyl also. If a baby in invasive ventilation, you can use midazolam. Then this bronchospasm part you have to deal with. I'm using the bronchodilator, and this tracheomalacia part, you have to provide an adequate PWP to open this malacia part. And now for inspired air to come into alveoli, you have to provide an adequate inspiratory time also. You have to prolong this I time 0.5 to 0.7. At the same time, you have to give adequate expiratory time also. So you have to keep the rate on the lower side and tidal volume to be set on 5 to 7 per kg. So by this, we can manage this BPD well. I think I put this slide here just so the importance of breast milk. It is not related to great talk, but whatever intervention we do with the NICU, the best intervention is the mother's milk. Even the BPD, the mother's milk have dose dependent effect. If you see this diagram, the baby, the first 4 weeks of life, with the baby intake of human milk is higher amount, that will decrease this BPD. Almost dose. If the baby having the 500 ml milk in the first 4 weeks, and maybe the incidence of BPD is this, and if the baby having this 3 liter of breast milk in the first 4 weeks, that's also reduce this BPD almost 3 times from this baseline value. So mother's milk is important even in the BPD also. Now coming to that is we must have knowledge and the skill at the same time. If we have only the skill, I think that is more detrimental, that will kill the baby. So we have to attend this workshop and we have to gain expertise. And at the same time, for learning ventilation, best thing you have to monitor the baby in the bedside. Otherwise, you do not learn. You will not learn the ventilation in this classroom or workshop. And what is said in the Goldsmith Book of Ventilation, there's a most important factor associated with safe and successful ventilator management of the sick unit is a person operating the ventilator rather than the ventilator itself. So my take-home message that we have to understand this pathophysiology and we have to ventilate based on this pathophysiology. At the same time, we have to minimize this ventilation-induced lung injury, and from the Point of intubation, you have to actively plan for weaning. And we should not forget the nutrition part also, even in ventilation. Thank you.
Thanks, Dr. Habibullah, for nice deliberation, beautiful slides, and all the presentation, all the 4 to 5 times the neonatal respiratory diseases. Bijan can now sum up the things and take over the questions which are in the chat box. Over to Bijan.
Thank you. Thank you, sir. Thank you, Habib, for an excellent or highest level of PPT or presentation. I think Habib has rightly discussed about the pathophysiology of the common respiratory morbidities. And based on the pathophysiology and mechanics, we have to settings. That is what he was discussing. So we should have good and thorough knowledge on pathophysiology of different respiratory morbidities. You have to know your ventilator because you may be using different ventilators, but ultimately the basic pathophysiology will be same. Second important thing, what he has highlighted, it is not the device, it is the person who is operating the device that is most important. Third important thing, what he has highlighted, based on the baby's response, you will titrate your ventilator settings. First of all, you have to know the pathophysiology, and based on your pathophysiology and modes of ventilation, you have to adjust your settings. And after the, based on the baby's response, we have to titrate your setting accordingly. Some of the important things we have here highlighted, like in RDS, here the compliance is low, resistance is normal or high, so the low time constant. So in RDS, maybe if you want to ventilate, according to the disease pathophysiology, you have to titrate your tidal volume. PWP, you have to keep on the moderate or higher side. Respiratory rate should be set on the higher side because the time constant is low. And because, so that is the mode of that is the setting what usually we set in the case of RDS. Another important thing is the severity of RDS. Suppose it's a mild to moderate RDS, then a mild to moderate setting. With a severe RDS, then you have to go on the higher setting. One important thing is that in RDS that there is atelectatic alveoli will be more. So you have to open the alveoli and you have to keep the alveoli open. So to keep the alveoli open, you use actually PIP. And to keep the alveoli open, you use actually PWP. And he was also discussing about the tidal volume. Tidal volume depends on the size of the baby and the dead space. That is why he was saying if the baby's weight is less than 1000 grams, the dead space will be more because the same, what is that called, flow sensor you are using, what is boosting the some of the volume will be lost. That's why we keep on the higher side. Same thing you are discussing when you are ventilating a baby with mass, then there will be a lot of dead space, so we keep the tidal volume on the higher side. But that is not true when you are ventilating a baby who has got hypognostic lung. Third important thing, he was telling that in a mass patient, you have to give adequate I time as well E time. That's why respiratory rate should be kept from the lower side, so that you get adequate TI as well. Pathophysiology of PPT is very complex, and that he was actually explaining well at different phases of PPT, the early phase, evolving phase, and the established BPT. And in our facility, many a times we actually encounter with established BPT, and that is a nightmare for a clinician. One important point was you were highlighting, we have to keep the tidal volume little bit on the higher side, maybe 7 ml, 7 or 10 ml per kg. And in the PWP also on the higher side. To keep the lung collapse, that choking point you have to prevent, and you have to keep the air upper airway patent. So that does not happen most of the time. As he was telling that many of these events, even the earlier part of PPT can on invasive ventilation. Same is true for babies with mechanoexpression syndrome and also babies with RDS. But as one important point he was highlighting, if a baby is having severe type of perinatal asphyxia or central type of breathing, then it is better not to do non-invasive ventilation, it may cause more harm than doing good. Many times, once you start using non-invasive ventilation very often in your unit, your knee-jerk response will be NIV only. But sometimes it may not work. You go for short intubation, short ventilation, your life will be easy. He was talking about various indications of mechanical ventilation, but one point to remember, mechanical ventilation can be actually done based on only on clinical setting. Suppose a baby is having shock, lung may be perfect, but you have to capture the baby's respiration. In that case, you can electively intubate the baby and mechanical ventilate the baby with normal physiological settings. So thank you, Habib, for an excellent and the highest level of presentation. I think most of the viewer, especially the DM residents, MD PGTs, they will be benefited with this presentation. So now we can take some questions. There are some questions in the chat box. We can discuss one by one. So Dr. Anisha is asking, does the value of PIP depend on the day or the gestation age of the baby? Habib.
It's basically depend on gestation, or you can if the baby is lower the gestation, usually PIP requirement in the lower side. If the gestation is on the term or late preterm, you can use the PIP on the hard side. And it also change depending on the as the day progress also.
So another important thing is that Habib has already highlighted PIP setting actually depends on the one is size of the baby as he has says. Second is that in clinical as a clinician you see the chest rise. There should be adequate chest rise. Third is that nowadays we are using volume guarantee ventilation. So you set a tidal volume according to the need of the baby. You see at what PIP baby is delivering the tidal volume. So that is the working PIP you have to keep. So, but if you are not using volume guarantee ventilation, you see the chest rise, you see the size of the baby, and this is pathophysiology. Maybe severe type of RDS, you may have to need more PIP to inflate the lung. But your chest should not jump. When you are clinically ventilating a baby, you just look at the baby. What is the chest size? If the chest is jumping, that means whatever PIP you have kept, that will move. And another important thing is the size of the gestation, but not actually day of life. Day of life, the tidal volume may be important because as the day of life increases, the weight of the baby increases. So in that case, tidal volume per kg will increase. Explain the. So the second question: how does milk decrease BPD? Bushra was asking.
I think this is the evidence. The mechanism maybe for different way, but because the mother milk, I think, have loss of anti-inflammatory factor like interleukin or TGF, or also have growth factor. I think there is also some so stem cell and microRNA also mother milks. The antioxidant capacity also mother milk also higher. I think there is a multifactorial, but BPD, it's evidence BPD is reduce this. Milk is reduce the BPD. I think that's.
No,
So
Habib,
How
in
is
your
uh,
Habib, in your slide, you have told the amount of breast milk from 500 to 3000 ml.
yes,
Is it
yes, yes, yes.
100% correct?
This basically this
Huh?
figure I quoted from the sir. Please listen. This figure I basically quoted from the on the latest study just published just 5 6 months back. In that study, that is basically a cohort study. They show this association. If the baby having this higher amount of breast milk in the first 4 weeks, there is decreased incidence of BPD. But important thing is that I think BPD is multifactorial. There is lots of factors related to BPD. So so reduce for reduction of BPD, you have to act different the different factor also. It's not only mother meals, you have to act on the other factor also.
Sir, what is Habib is trying to explain us? BPD is multifactorial. One of the most common factors which is responsible is inflammation of the lung and infection, and there is oxygen-related damage. And breast milk has all their properties which can counteract all these inciting factors. That way, it might actually reduce the adaptation of BPD. Another important is the lung growth. If you give adequate nutrition, lung growth will be there. One of the important strategy for prevention of BPD is nutrition. So if you give breast milk, it will give all the support, all the nutritive elements what a baby requires. Sir, please, Mohammed Ashraf, please explain the role of time constant in different conditions. I think we have already discussed. In a RDS,
Yes, sir.
time constant is low, that's why I keep the respirator on the higher side. In a mass, time constant is high, that's why I keep the respirator on the lower side. Same thing is for BPD. There the resistance is high, compliance is high, so time constant will be high. That's why you keep the respirator on the lower side. So I think this explains your my questions answer. So Arnob is asking, Lisa is more effective than early rescue surfactant in decreasing the incidence of BPT, 43% versus
I
30%.
think
How?
this is two different things you are combining. That is the early rescue surfactant, and another is the laser technique. If you use the early rescue surfactant, that will decrease the BPT, and the laser technique is different. If you, I think you are combining these two methods here. That it's not like.
So,
Uh,
so if you, because if you see one important thing here, you are saying even 6 manual ventilation is enough to cause lung trauma and ultimately leading to BPT. If you use laser, that means you are avoiding mechanical ventilation and intubation. And at the same time, baby is getting adequate respiratory support in the form of FRC. So there are some theories, hypotheses, and there are a lot of evidence which has clearly shown by actually adopting laser strategy, incidence of BPD has come down. So one reason is this, because even 6 manual breath, that's why is our humble request to all of you, when you go to the delivery room, do gentle manual ventilation, because with your hand you can increase the pressure more than 40 centimeter water pressure. So animal model has shown that if you provide 6 breath, more than 40 centimeter water pressure, this will be enough to cause lung damage and ultimately leading to BPD. So Anisha is asking, so we will titrate as per the need of the child. Exactly. It is the baby who will tell you what should be done. It is not you and me. If the baby is retracting a lot, that means baby is asking for more PWP. His FRC is not established. If there is no chest rise, the baby is asking that you have to provide more PIP. If the baby is having increased work of breathing, that means your ventilation strategy is inadequate. If the baby is not breathing is not at all, that means you are hyperventilating the baby. So it is the baby who will tell you what should be done. So we have to actually prospectively monitor the baby once you are ventilating. You cannot just give a setting and go away and baby will improve on its own. That will never happen.
All,
Any more question? I don't think
all questions are
there are,
covered.
all the questions are actually covered. And if any more question you want to ask, you can ask or you can write in our group. Our speakers will be happy to answer your queries. But one important message to all of you, if you want to learn ventilation, you have to be by the side of the baby. You cannot just what Habib has given you the suggested settings for mechanical ventilation or disease specific settings. These are suggested settings, but this setting has to be dynamically changed. That is why in one slide you were saying, you were telling one size does not fit all, and we should follow that principle. That means every baby is different, the disease changes from time to time, and another important thing is that you learn ventilation by staying with the patient, and you have to have some objectives in your mind, and you see after ventilation your objectives are fulfilled or not. It is the experience of the clinician and it is experience of other clinicians which combine and make optimal ventilation. I think if any more question you can ask directly, you can unmute, or if you do not have any questions, I think we'll close the session today or tonight.
Yes.
Any more question? You can take 1 or 2 questions till now if you are interested.
Nobody is there.
Nobody is there. I think thank you, Habib, once again for your
Yes.
excellent presentation and
Excellent.
Thank you,
insight
sir.
of the subject. I think this will have a very good impact on our students. They will be benefited. And it is my request to all of you, start ventilation, learn the things, do it regularly. By doing ventilation, never too hard. So we have to avoid BILI and we have to minimize ventilator associated lung injury, and also we have to optimize ventilation. Thank you very much. Thank you for your patient hearing. I think we can close the session tonight. Thank
Yes,
you.
yes, we can close the session. Thank you, Dr. Habibullah, for your nice deliberation, beautiful slides, and your thoughts and everything. And Dr. Bijan has explained everything. You have to stay with the site of the ventilation. Otherwise, it is very difficult to learn all the difficult things, all the positives and negative things which we have to face during the ventilation period. So, with these few words, I am closing the session. Thank you very
Thank you,
much.
sir. Thank you, sir. Thank you all.
Thank you,
Good
sir.
night.